And
Like, where do you get more views? YouTube or on the Zoom?
usually Zoom, but we get a fair amount on YouTube. What happens after YouTube is it gets archived on my webpage, and then we get like often like 2,000 views after, right? People often will look after, right, and do that. So we got a newbie from VCU, Richmond, Virginia. All right, was that one of the swing states in the election? I don't remember. I'm kidding. Indonesia, Sri Lanka, fantastic. Ali's back. Good to see that as well. Yeah, so basically, Zoom and YouTube, and then on YouTube, we'll typically get like between 1,500 to 2,000 watching it after. So it's kind of nice. People have different time zones. Since we moved it, hello from Exotic, South Dakota. Who's that guy? But we get it's tough for our European colleagues to attend when it's on an evening. So we tend to get them watching the next day.
Hello from Switzerland. That's cool.
Ravi Goals here. Tissi Boa Noite from Brazil. Awesome. Representing one of our former fellows who's now off in Brazil.
Well, we should drag her into the panelists.
We should. Why don't you ask her if she wants to come on?
Yeah.
I'm sure she's ready.
Yeah,
Lisbon, that's fantastic. Garth Wilbank, he's a regular from Maine. From Nigeria. Brian, you got folks from Nigeria watching you. It's pretty cool, isn't it? Zoom's pretty amazing. Switzerland. Lorenz, you guys got to check out Lorenz Kuska's YouTube channel. This guy is quite the producer. Awesome. Fantastic. Okay, so I will pass it over to you, Matthew, to get started, and then
totally have a Pittsburgh.
I'll say a few comments, and then we'll get into the presentation.
Awesome. Thanks, Ike. Okay, guys, so we're here talking about some interesting topics in extended depth of vision, extended depth of focus / multifocal IOLs in patients with glaucoma. It's kind of something I'm interested in personally, but also a very new kind of idea. So pretty controversial. Let me start screen sharing here so I can do a little bit of an intro to our speaker here. And we've got some stellar panelists, superstars. Thanks for joining us.
And by the way, if Matthew seems a bit tired, he's been operating like a madman for the last couple of weeks, doing like
tell me I look tired,
running complicated cases. So
I've been spoiled totally. Let's see here. Are you guys seeing my screen now?
Yes.
Awesome. Okay, so we've got a buddy here, Brian Schaefer, who's kindly agreed to put together a presentation on the topic. Current fellow in corneal refractive glaucoma and anterior segment advanced Thompson vision with Dr. Berdahl. So Brian is a Philadelphia native, spending a year up in the upper Midwest to gain expertise in all these things related to anterior segment under Drs. Berdahl, Vance Thompson, and Daniel Terveen. Particularly interested in IOL technology, MIGS, patient experience, drug delivery, and ophthalmic education. So here we are. He's also got a 3-month-old boy who he and his wife, Morgan, are absolutely obsessed with, and I quote. So thanks for joining us, Brian. Appreciate it. And thanks for convincing Dr. Berdahl to join us too. So Dr. Berdahl is a rock star. Residency at Duke, cornea, external disease, glaucoma, refractive surgery fellowship in Minnesota. And the list of achievements are epic. So, it's really fun to be here with you guys, you're rock stars. I'll leave that up just for you to sort of peruse, but all sorts of amazing awards.
You may have to move the slides a bit.
Slides are not advancing.
Oh.
We taught him how to suture and lenses, but not to hit the forward button on the presentation.
No, yeah. I don't know. It must be stuck. Let me reshare.
Maybe I'll take the opportunity to just welcome John, because John is definitely a guy I consider a great friend and a colleague. Someone I've been watching since he got out of fellowship, where he did it at one of the premier fellowships at the Minnesota Eye Consultants. There's a few people I really listen to when they speak. John, in his young age and his early career and being in the middle of South Dakota, which is now a hot spot, but often is the cold spot, so to speak, has just done an enormous amount of work. And, innovation, entrepreneurship, surgical creativity, great, nice guy, fun guy, very articulate when he speaks with authority. You can see he's gotten grants from NASA to many other agencies, been selected for so many different awards. But I think those of you who spend time with him know how genuine he is. And it's easy to look at someone like John. And yes, he's a good looking guy. I will say that. And think this guy's a cocky SOB. You know what? It's like, this young guy, trajectory going through the roof. But, get to know him, and you know him when the first time you meet him, how humble he is and how really he's doing it for the right reason. A family guy, just, really, really super nice and really in it for the right reasons. But yet very cutting edge. It's something that you don't see a lot. So sorry, Matthew, I took some of the introductions from you, but I thought I'd take advantage of the free time I had. But honestly, it's a real privilege. I really mean that, to have John here, to be one of the panelists here. John, you're such a great guy. We spent a lot of time over the last few months doing things together. So thank you for being part of our rounds. It's really kind of you to be here.
Well, that means a ton coming from you. And, you're the straw that stirs the drink in ophthalmology, and how much you give to the profession and your dedication and doing things like this. We're just following in your wake. So thanks.
Well, apparently I have a man crush, according to Sandra. So on the chat group, so that's probably true. Okay, Matthew, back to you.
Thanks, Ike. No, that was great. I couldn't have said it better. So I'm glad you took that over. And it sounds like someone else I know. You guys are awesome. So thank you so much for kind of letting us tag along, us newbies and younger folks. Brian, why don't you take it away? I'm going to, or actually, Ike, you're going to go ahead and share some cases of yours first.
Yeah, do you want to introduce also Ricky and Drew as well?
And yes, so Ricky, who has been on here before. So glaucoma anterior segment extraordinaire, MD, PhDs, really smart enthusiast, and actually just started recently an Instagram, right? Master the Pressure. So check that out. She collects cases and posts them on there. Ricky's just...
I'm going to have to interrupt you there, because if you're going to mention Master the Pressure, we have to also mention Finney John at Oklahoma and Raghu at Wills and Sachin Colin at Case.
And we'll get those guys on here soon too.
That was originally my idea.
Yeah, you deserve the credit, and so do they. So anyway, can you introduce Drew, since you helped us get him on here?
Yeah, absolutely. So Drew Davis, he and I go way back, 10, 12 years? I don't know. So Drew was a year ahead of me in med school. I was an MD PhD and decided to stay in training forever, while Drew went on to be a high volume cataract refractive surgeon straight out of training. I believe it was University of Wisconsin for residency. Is that right?
It was Medical College Wisconsin in Milwaukee.
Medical College Wisconsin. Okay. And then, so then he moved to South Bend for a couple years, went to Whiting Clinic in Minneapolis and was their head LASIK surgeon at a big refractive practice there.
The head refractive cataract surgeon. Dr. Whiting was still on with me, but yeah.
Okay, fine. Okay. You probably should do this. Yeah, no. All right. So refractive cataract surgeon.
I'm still impressed.
But now he's back in Southern Indiana with Pancratz. Is that right? Eye Institute?
Yeah, it's another cataract and refractive referral center for Southern Indiana. About an hour from my wife's family, instead of 13 hours or whatever it was. So.
Yeah, I'm doing all this from memory. So Drew's a great guy, though. He and I've been good friends for a long time.
Thanks everybody. Who the hell invited this long-haired Mexican hippie guy?
Yeah.
All right, Havo Campos has bombed us here. We'll see if he's going to say anything. But Havo,
why did you invite me? I was supposed to be a participant, not a panelist. But
that was a mistake. That was a mistake.
Yeah.
All right. Well, listen.
I'm not even a doctor.
Yeah, well, that's probably true. But he's a surfer who surfs in -10 degrees in Newfoundland. That's
true.
Something to think about and write about. Okay, well, listen. So happy to have everybody here. This is going to be an exciting rounds here. A little bit of controversy. We have experts here who have expertise in refractive cataract surgery, IOLs, and glaucoma, and we hope we can stir the pot a bit and maybe talk about experiences and also some evidence. I'm going to quickly go through some cases, and then we're going to hand it over to Brian, who I'm super excited to hear about. He's, again, on a great trajectory, doing a fellowship with John and Vance Thompson. This is the first case, a patient who's had some stable glaucoma. You can see over the last year or so, the visual field is pretty clean. There's some early RNFL changes. You got some OCTs from the past. Okay, question, would you consider a multifocal or EDOF lens in a patient very motivated to be having spectacle freedom? Here's another case. This one's stable, a bit more mild to moderate. You can see the left eye here. We do have some progression analysis here, which shows fairly stable visual fields. But the RNFL does show substantial RNFL loss, you can see on the left of your screen here in this patient with what we would call moderate glaucoma. Would you consider a multifocal or EDOF in this patient? How about this patient here who's got advanced glaucoma, pretty well lost the superior hemifield. The inferior visual field is showing some loss as well. You could call it stable. At least we only have 3 visual fields here. Basically, the RNFL looks like South Dakota on a November morning. Multifocal or EDOF as well. And as you can see here, actually, this patient here was actually quite upset because he basically had heard about a multifocal and he wasn't told about this option. And he was basically upset that why was he not told about multifocal, okay? Yeah, this patient here who has shown some progression, you could call it maybe early defects on the visual field index, but the visual field is in the central zone, which we often see in early glaucoma, and the classic macular vulnerability zone being affected as well as inferior RNFL loss in this patient. So the question in these cases are, will we consider multifocal or an EDOF lens? And I'm going to hand it over to Brian with the appetite for folks and looking forward. We'll come back to those cases later on, but Brian, over to you, buddy. Thank you.
I want to start by asking you guys all a question. Do patients with glaucoma deserve to have their presbyopia managed? Just because a patient has glaucoma, are they not eligible to wear reading glasses? The answer is of course. Of course we should manage patients' presbyopia, even if they have glaucoma. But how about at the time of cataract surgery? Like I just mentioned, when the patient comes in, they say, I've heard about these advanced optic lenses and I want to be spectacle independent. Just because they have some glaucoma, do they no longer deserve to be spectacle independent? And why is this even a conversation? Here's why this is a conversation. I do not recommend using a multifocal IOL for patients with definite glaucoma, no matter how early. Multifocal lenses may be an inadvisable option for glaucoma patients. For a number of reasons, multifocal lenses are likely to have negative effect on quality of vision in these patients, surgeon says. As glaucoma patients already have compromised contrast sensitivity, a multifocal lens can actually make their vision worse. Multifocal IOLs are probably best avoided in patients with advanced glaucoma. Proven glaucoma multifocal lenses? No. Well, for the past 2+ decades, this has been the dogma. The dogma has really been a 3-pillar dogma: contrast sensitivity, pupil size, and refractive stability. This is why this has been controversial for 2+ decades. The biggest of these is contrast sensitivity. This is the first non-starter for most people when you say, should I put a multifocal lens in a patient with glaucoma? Almost every single person's response is, well, I worry about contrast sensitivity. So let's talk about that. What is contrast sensitivity? We all kind of know what it is, but do we all feel like we know what it is? If we look at this picture on the left, this is a picture showing you what reduced contrast might look like. On the right side of the picture on the lake, you can see a nice crisp lake with the swells in it. And then on the left side of it, it just looks a little bit washed out. I think that most of us probably think about this when we think of contrast sensitivity. But what does it actually mean when we go to talk about contrast sensitivity in a patient or with a new advanced optic lens? It's important that we understand how these lenses are evaluated and how they're graded. And what we do is we look at this contrast sensitivity chart. On the y-axis, we have contrast sensitivity, and on the x-axis, we have the spatial frequency. Let's just take a quick moment to understand this together so we're on the same page. On the y-axis, we have contrast sensitivity. As you go up the y-axis, contrast sensitivity increases, which means that you're more able to see letters with lower contrast. On the x-axis is the spatial frequency. Spatial frequency is like the teller visual acuity that our pediatric colleagues use, with lines that are spaced far apart and then closer and closer and closer together. When the lines are extremely far apart, like you can see on the bottom left of the graph, those lines being so far apart, it's actually a little bit more tricky to see them because they start to blend together. As you get to spatial frequencies of 3 to 6 cycles per degree, that is where most of our human perception lies. That's catching a baseball that's coming at you. That's seeing the traffic light. That's being able to read the traffic sign. That's recognizing a face when it walks towards you in the hallway. As you go across spatial frequency, those lines get closer and closer and closer together. When you get to a spatial frequency of about 12 cycles per degree, that's when things are so small and so close together that even to a normal human eye, it starts to become a little bit more imperceptible. How do we actually measure this? Well, we do it by looking at the Pelle-Robson chart, a chart that we all know and none of us use. But I figured that with this chart that we've all seen before, and none of us have really ever measured patients' acuity on it, we can look and actually evaluate what it means for a patient to have reduced contrast sensitivity. If a patient comes in and reads the Pelle-Robson chart, they need to get a full 2 out of the 3 letters in each of these triplets to count as meeting criteria for having seen that contrast. If you look at the top, the VRS, that's the highest contrast letter, and therefore you need the lowest contrast sensitivity. The number on the left-hand side of the left-hand triplet and the right-hand side of the right-hand triplets represents the contrast sensitivity score in logarithmic scale. The reason it's in logarithmic scale is just because the numbers come out better and make it much more linear. In order for something to have a clinically significant reduction in contrast sensitivity, you need to have a 0.3 log reduction in contrast sensitivity. Now, what the heck does that mean? We can read that and we can say that, but what does it really mean? What it means is this. It means 2 triplets lower on your Pelle-Robson chart. So if you have a contrast sensitivity score of 1.25, you can read the NOD there. If you lose clinically significant contrast sensitivity, you now can only read the CNH. Now let's put this into more clinical context. This is a chart showing what a normal person's contrast sensitivity would look like versus those with mild, moderate, or severe glaucoma. Let's put that next to the Pelle-Robson chart, and let's focus in on spatial frequencies of 3 to 6 cycles per degree. Remember, this is where human vision lies. This is recognizing the face when it's walking across the room from you. This is catching the baseball when you're having a catch with your son. If we look at a normal eye, we can see that the normal contrast sensitivity is greater than 2. That means we can see the very bottom line. And most of us can really make out those bottom letters. It's not easy, but we can do it when there's good lighting in the room and a good environment to evaluate for good contrast sensitivity. But how about with glaucoma? And why has this been the conversation for so long? It's because of this. With even mild glaucoma, with a mean deviation score of 0 to -6, you have reduced contrast sensitivity to the point where you can only see the ZSV and the KCH. Now, I don't know about you, but there are very few things in my life that I look at that are that low contrast where I really wish I could see it a lot better. That's really low contrast. And that's still really good that they can see that in normal settings. If we go down to moderate glaucoma, we can see we're starting to go down the triplets here. We're losing some contrast. When we get to severe glaucoma, we've lost even more. Now, let's take this and remember that this is the baseline contrast sensitivity of each patient with glaucoma. A patient with severe glaucoma has a contrast sensitivity score on average of about 1.1 or a little bit less. That's reading the ZOK. That's fairly low contrast, but still seeable. Why was this such an issue for so long? Because back in the old days, it really mattered. When we had our original multifocal IOLs, our refractive IOLs and the original diffractive IOLs, contrast was a big deal. Not only did contrast sensitivity reduce in patients with a multifocal lens of our original generations in somebody with glaucoma, but our contrast sensitivity was reduced in normal eyes too. In other words, everybody kind of lost some visual quality when you put in a multifocal lens. And therefore, if you had somebody who was already predisposed to having lower contrast sensitivity and you put in a lens that decreased their contrast sensitivity even more, that's a big deal. But don't forget, guys, we're living in the future now. We have a new era of presbyopia correcting IOLs. We've got the Panoptix trifocal lens, we have the Symphony EDOF, we have the Vivity extended vision IOL, and we have RxSight's light adjustable lens, which does have a little bit of depth of focus to it. Let's dive into these lenses a little bit. If we look at the FDA data for the Panoptix trifocal lens, where they compared the mesopic and photopic binocular contrast sensitivity on the Panoptix versus the monofocal equivalent, the SN6AT, you can see that although maybe it looks like that gray line, which represents the Panoptix, has a slight dip in contrast sensitivity, remember that clinically significant decrease in contrast sensitivity is 2 triplets on that Pelley-Robson scale. It's 0.3 log, and this does not meet criteria for clinically significant reduction in contrast sensitivity. If we look at the Symphony EDOF lens, similar story. It does not meet criteria for clinically significant reduction in contrast sensitivity. Our newest exciting lens out on the market is Alcon's Vivity extended vision IOL. This is our first non-diffractive multifocal extended depth of focus, not multifocal, extended range of vision IOL that uses X-Wave technology. And what we can see here very nicely on their chart, they put the red line. This red line represents 0.3 log reduction in contrast sensitivity compared to their Acrosoft monofocal equivalent. The blue line is representing Vivity, and it's clear as day that with the binocular mesopic contrast sensitivity data from the global studies, they do not achieve a clinically or statistically significant reduction in contrast sensitivity. That's important. And if we compare the Panoptix versus the Symphony here, and we look at the two of these lenses and remember that they weren't clinically significantly different from their monofocal equivalents, let's look at what it means to be able to see through these lenses with a normal eye. At a spatial frequency of 3, remember that's our normal range, you can see the CDN. Again, that is really good. That is a very low contrast triplet right there that anybody would be happy to be able to see that well. When we get to a spatial frequency of 6, it's even better. The ZSV, log of 1.7. We can really see far down that Pelley-Robson chart. Now, when we get to a spatial frequency of 12 cycles per degree, we're starting to talk about what it means to be reading a book in the dark, a bedtime story in the dark to your child. That's not easy for anybody, but a spatial frequency of 12 with these lenses still allows you to see pretty good. Once we get to a spatial frequency of 18, that's basically non-human vision. That's not vision that we're using day to day for anything, but you still can see almost as good as somebody who baseline has severe glaucoma. So let's pause on this for a second. Can we move on from talking about contrast sensitivity reduction from our IOLs because they don't anymore? It used to be so relevant, but it's really not the story anymore. Likewise, let's talk about pupil size. Pupil size really used to matter. In our resume and restore lenses, pupil size was sometimes a differentiating factor about which lens you were going to put in the eye. If somebody had a very small pupil and they were only going to be able to focus through the near optic on their resume lens, that wasn't going to be functional vision for them. Now, one caveat for where this still matters in one of our new lenses is the RxSight's light adjustable lens. And the reason that's important is because when you actually go to adjust the lens, the patient needs to have a 7mm pupil in order to focus that light and change the shape of that optic. But let's talk about our lenses now. Does pupil size matter? The Symphony lens, the EDOF lens, the Panoptix, and the Vivity lens are all marketed as pupil independent lenses. All of these lenses function beautifully at a range of 2 to 7mm pupils. Now remember, anybody with a 1mm pupil is going to have their own pinhole effect through that pupil, and their vision's not going to be as good. Likewise, if they have a pupil that's 9 millimeters at baseline, the amount of spherical aberration induced by that gigantic pupil, whether they have a multifocal lens, a monofocal lens, or their own crystalline lens, their vision is going to be greatly degraded. So pupil size, again, not really part of the conversation, even though it's part of that dogma. Now, the final piece of the original dogma, refractive stability. What we know about patients who have glaucoma compared to patients who don't have glaucoma is that their refractions are stable. There's no change in the refraction over time in somebody with glaucoma just because they have glaucoma. However, in a patient who had glaucoma, who may progress to needing surgery prior to a few decades, their only option was incisional glaucoma surgery. And what we know with incisional glaucoma surgery is that it does change your refraction. If you look at this trabeculectomy with a low-hanging bleb on the right-hand side here, do you think that patient's going to have some induced astigmatism and degraded visual quality regardless of what kind of lens you put in their eye? Because I think so. But this isn't what we do in glaucoma anymore. We work so hard in glaucoma to avoid this point. We're in a modern age of glaucoma surgery. Most of the glaucoma surgery that we do is angle-based. We're doing goniotomy, trabeculotomy, canaloplasty, stenting, selective laser trabeculoplasty, endoscopic cyclophotocoagulation. We have so many more options than we've ever had before, and our goal is to avoid someone progressing to incisional glaucoma surgery. And therefore, it's important to recognize that MIGS and SLT do not impact the refractive stability, they do not impact the refraction, and they do not impact astigmatism. Therefore, if a patient is not going to have incisional glaucoma surgery, their refractions are going to be pretty stable. So I believe we're entering a paradigm shift. The old dogma was, don't put in that lens because it's going to ruin their contrast sensitivity and it's already going to be ruined. But our new lenses don't change contrast sensitivity from our monofocal equivalents. Would you penalize a patient who has a cataract and glaucoma from getting a monofocal IOL because it reduces contrast sensitivity? You wouldn't. So why would you do the same with the multifocal? Because they don't change their contrast sensitivity. Additionally, pupil size, of course, with the exception of the light adjustable lens, these lenses are pupil independent now. And most of our glaucoma can be managed with MIGS or laser surgery or drops at this point. So it's a paradigm shift. And what I'm saying is not go put multifocal lenses in absolutely everybody with glaucoma, because sometimes it is truly important to think about this. And here's where it's important. Where I believe it's important is when you talk about the glaucoma severity, etiology, and age, and together those really make up what is the trajectory of this patient's glaucoma. If you have somebody who presents with mild glaucoma at a young age with really high pressures, and you're just not sure how they're going to progress, you want to watch them. You don't know what their trajectory is going to be. Likewise, if you have a patient with moderate or severe glaucoma already, and they're at an older age, you kind of have a sense that their trajectory is one where they're going to lose vision from glaucoma. They're going to have real vision loss, and their foveas may be threatened. We also, in addition to the age and the baseline severity, have to really think about the etiology. Mild primary open-angle glaucoma, Tmax of 24, controlled on one med, never really progressing, easy. But this patient on the top left who presents an angle closure with NVG, that's a different story. That's a big time different story. Are you going to take out that lens right away and put in a multifocal lens? I wouldn't want that for my eye. You don't know where this patient's going to go over the next couple of months to years. Likewise, the middle picture here is somebody with pigment dispersion glaucoma. Sometimes these patients will present in their 40s with severe vision loss already because they've had really high pressures that they haven't known about. These are the patients that we need to watch very closely because they could easily lose vision. Finally, the bottom left here, you have a pseudoexfoliation patient, and this is a twofold. One, you don't know how their glaucoma itself is going to progress, and two, you don't know how stable that lens is going to be in the eye. Now, you may say, if the patient can get a good decade out of a stable multifocal IOL centered in their eye, and then it dislocates, so be it. They got 10 years out of it. What I would challenge for that is that if you have a patient with pseudoexfoliation and you put a monofocal lens in their eye and it dislocates a little bit, the optic and the optical zone of the monofocal lens is such that they may still have excellent vision, even though that lens is slightly dislocated. With a multifocal, if they're shifted off of the center optic and they're just looking through the diffractive zones, that could be a bigger issue, a much bigger issue. And the final piece of that is don't neglect the ocular surface. What we know is that our new advanced optic IOLs work best when the ocular surface is pristine. The epithelial tear film interface is the most important refractive element of the eye. We all know that. What we also know is that the majority of our glaucoma patients show up to us asymptomatic, and they leave our office symptomatic because we've put them on a glaucoma drop that hurts their eye. We now can be a steward for this patient and get them off of their drops, optimize their ocular surface, and make them amenable to an advanced optic by doing one of two things. We now have so many MIGs available to us, including lasers. But the other thing is that we now have our first injectable bimatoprost implant, which also is just a step in the right direction of getting patients off of their drops. So I want to ask you, don't you always do what's best for the patient? The answer is yes. And in this situation, the conversation with the patient is, you have glaucoma. Your glaucoma right now is mild. You have risk of losing vision long-term from this, but you don't have vision loss right now. We think we can control your glaucoma in the long run, and we think that you would benefit from an advanced optic that would lead to spectacle independence. The other conversation may be different. You already have glaucoma. I'm so sorry that you have so much vision loss from your glaucoma already. Is it enough value to you for you to spend your own resources for an advanced optic IOL that you may not get the full benefit from? That's the conversation that we start to have with our patients. And we all want to do what's best for our patients, and we all want to focus on what matters for that patient. So I implore you, focus on what matters. This is what matters to me. So what matters for you? Thank you.
Great way to end. Thanks so much, Brian. That was a great review. I certainly learned a lot, just even on the contrast story. And I think there are many questions that come up. I wonder maybe I could get John perhaps to throw in his thoughts on this issue, and then we can use some cases perhaps to talk about things. And then there's some questions on the chat group as well that I think we want to get into, which I think are some really good questions about some of the warnings from the FDA and other things as well.
Yeah, so I think that, my take home, Brian, really nice job on your talk. And my take home was that I see the cycles per degree curves a lot of times, but I don't ever really internalize them. And I think that you kind of made that real to us a little bit. And I think that that's really helpful in terms of thinking about it through our patient's eyes. So, my take on it, and I remember one time gave a talk about correcting astigmatism at the time of cataract surgery in glaucoma patients. And I kind of felt like, well, we're going to correct their astigmatism. It's either going to be in their glasses or it can be in their lens. And so, that's a little bit lower hanging fruit because I don't think that we have the contrast sensitivity issues. Now, the question is what's the trajectory of that glaucoma going to be as you raise that question? And how much potential compounding contrast sensitivity issues do we have, especially in low light? And are we willing, and is our patient willing to take some risk along with us to live the life that they may want to live with more spectacle independence? So that's the question that I ask myself every time, Mike. If it was me and it was my eye, or if it was my mom, would I offer this technology to this patient or not? And I think, my take home is mild glaucoma in a patient that's well controlled and a little older, I got no problems with a multifocal and an extended depth of focus lens.
So I wanted to just maybe have just some questions that came up here. Maybe we'll go through that. And again, Matt, if you see something, then let's do it. And we got Havo, Ricky, and Drew here as well. So a question came up from Patrick. What about in dim light? Would a loss in optimal conditions transition into a meaningful one in dim lighting?
That's a fantastic question. And that is where the cycles per degree chart starts to move towards the 12 and 18 range. And I think that the answer is yes, that there is meaningful decline in contrast sensitivity in every single one of our IOLs, not just our multifocal IOLs. And I think that patients who at baseline have enough reduction in contrast sensitivity would be just as sensitive with a multifocal lens, with an advanced optic lens, as they would be with a monofocal equivalent. And to that point, they will be sensitive to that because that's what their glaucoma is doing. Really, the mean deviation, if you look at contrast sensitivity and compare it to mean deviation and compare it to visual acuity, and you try and figure out a comparison between those, mean deviation and contrast sensitivity are very closely linked. Visual acuity is not at all linked. So at those dim lights, I think that anybody with glaucoma is going to suffer. I don't think they're going to suffer anymore with an advanced optic IOL at this point.
Okay. So I thought maybe we can get into some questions about, because there's been a lot of discussion, of course, on some of the new IOLs. I mean, of course, I think there's been a lot of press with the latest extended vision lens, the Vivity lens. Of course, well, sorry, not in the US, but there's been some newer multifocals like the continuous range synergy lens and also the iHance lens. So there's all these new lenses that are coming about that are beyond what a monofocal does, but doing a different way. And maybe just to help the audience to kind of orient, I'm going to just show a brief review of some of the lenses out there, and just to help people differentiate what some of the lens technologies are, just to kind of orient people. Let's take a minute to do this to get people oriented. And I apologize, this is just a quick presentation here, but in Canada we've got these. And my apologies to my U.S. friends because these aren't all available in the U.S. But we've got a variety of now basically our trifocal, what we call multifocal IOLs. Near, intermediate, far vision, and the latest Synergy, which basically is again also a type of multifocal, but has maybe perhaps a bit more of a continuous range, particularly for the near point, but essentially providing a pretty long range and essentially working with some splitting of light, right? And we see defocus curves, for example, showing the distance, intermediate, and near. And again, depending on what lens you see, there is sometimes a bit of a drop off, for example, with the typical bifocals that we see, but the trifocals have been able to address that as well. Again, examples of bifocal implants with different ads, and this corresponds to different, working distances. It is true that there's some contrast loss, and I think we can certainly debate how much contrast loss is enough. We've all had patients, of course, that we remember, not a lot, that have multifocal lenses that come back and they have this waxy vision and they're just not happy. It's not common, but we do, of course, remember these, and that's why sometimes we worry about contrast, albeit perhaps, and as Brian said, the latest lenses typically have less as well. Now, I think when we talk about extended range of vision lenses, there are different ways that this can be addressed, and it gets confusing out there because a lot of strategies are out there: spherical aberration, zonal changes, refractive power changes, diffractive technologies like for example, Symphony, wavefront shaping, which is what we would call the Vivity, pinhole lenses that are now in design as well, and then hybrids as well. And the ones that we have currently are the Symphony, which I think we all are familiar with. Sorry, spelling mistake there. And you can see the diffractive rings. We have the Vivity, which you see is not a diffractive lens, but has this surface transition zone, very small, subtle transition zone, which basically stretches and shifts light to provide intermediate vision. And then we have the iHance, which isn't really classified as a typical EDOF, but does provide some additional intermediate vision by adding a small, subtle power change to the center. So these are basically the EDOF lenses. And I'm just going to go right to a question that I think somebody asked here, which is this point right here, which is basically a warning on the FDA, which basically showed, oh, sorry, not this one here, which basically showed, which came up here basically was here, which basically led to the FDA warning on a Vivity lens, which you can see here, and Brian nicely showed, clinical meaning field about 0.3 logs here drop at about at the higher spatial frequencies, and this was with monocular. So that came up in the FDA warning. I will say now that with binocular testing, we don't see the same amount of drop off, and this is within that range. And Brian showed this nicely. So that question came up. I think it was James that maybe asked it about why the labeling, and maybe we can get Brian or John to address this question, maybe specifically to that point. In that Vivity. So the first question I'm going to ask you, Brian, came up here is: do we have any ideas or knowledge about the contrast loss, whatever it is, between a Vivity lens and the typical trifocal? That was one question that came up here.
There is a similar type of contrast loss between the Vivity and the Panoptix, with the Vivity having just slightly more contrast loss measured by their standard systems. They had to put that warning on because in a monocular contrast sensitivity test, it dropped down by 0.3 log. In their global study where they looked at binocular, which is how most studies are done and how we do use our eyes, it passed. And that was the graph that I showed. And one thing that I think they did well after the fact is they decided to test something that I didn't touch on here, but is worth talking about and might be a better way for us to think about this in general, is they showed low contrast vision. So basically they set a room up so that they put up a chart on the wall, like an ETDRS type chart or a Snellen acuity chart, in low contrast, and check the vision that way. So instead of checking the contrast sensitivity the classic ways that you can do so with looking at the specific lines that are closer and closer together, they just put a chart up on the wall with low contrast and then check the visual acuity to give you a more real world example of what their vision might be like. So it's an unfortunate reality that they didn't pass the monocular contrast sensitivity scale, but their functional vision was still excellent.
Yeah, and one of the things that's challenging about going to the literature on this with doing multifocals or extended depth of focus lenses and glaucoma is, a lot of us kind of have avoided it. So how do you create the study to do it to help guide us when the natural tendency would be to be more conservative? And, you're right about the contrast sensitivity warning and decrease in mesopic conditions and photopic conditions. It wasn't there. And then also, like mentioned in binocularity, it didn't meet that 0.3 threshold. But all of this is the data that we try to use to be good stewards of our patients' eyes. And, it makes me wonder, let's say you did this with a MIGS procedure and you got somebody off a drop and their ocular surface is maybe a little bit better. What's going to end up with the better quality vision? And I think that that's kind of what the debate is about.
Well said. So Brian, I'm impressed with your knowledge of the literature, and this is just one of the studies that were done with Vivity, just looking at low contrast visual acuity, which is a more functional, and you can see that really there was minimal issues with regards to compared to monofocal. So I think there's sort of a difference in the lab versus what we see often in real life, as you mentioned. I will also mention, I don't know what your experience has been, and I don't want to just highlight Vivity only, but obviously it's a hot topic and there's questions about it. But the one thing that's remarkable in our experience has been just the lack of dysphotopsia. And that's one thing. And I'm not saying that glaucoma patients have more dysphotopsia than non-glaucoma. You can argue that point, but that's an attractive option for patients who want to have some good intermediate, and even some near, which I've been really impressed with. I don't know, John or Brian, if you have any experiences. Drew, maybe I want to bring you into the conversation as well. What are your thoughts on where Vivity fits in that? And by the way, this is not a sponsored symposium. It's a hot topic, of course, in a new lens.
Yeah, I haven't gotten my hands on the Vivity yet to try it out, but I'm excited about it for the same reasons you are. Brian, can you show that Symphony slide again with the Symphony's contrast sensitivity to get an idea of what we can expect from Vivity?
Sure.
Because I'm pretty familiar with the real life, adjustments from Symphony and what I hear from my patients and what I see. And I don't really see anyone really complaining about much about that type of thing, as far as inability to see in dim light and that sort of thing.
Give me one moment to get to it here.
And while we're doing that, to answer one of the questions about, moving away from apodized optics, I think that that's right. I think that we did have issues with the Restore lens, with the Restore 3.0 lens, with waxy vision, and with, up close and dim light vision. We got those complaints not infrequently with those lenses.
Yeah, Ike, we have been putting in the Vivity for commercially now for a little bit, and we're seeing those patients back, and we're using it similar to how we would have used the Symphony lens. We are not promising near vision, but what we are telling them is that they will have the ability to have a little bit more spectacle independence and a little bit more depth of focus without the added glare and halos, the photic phenomenon. And that's reigned true for them. And a lot of them, we are offsetting them a little bit by about a half diopter. We're still playing around if should it be a half diopter or 3/4 of a diopter, but it's giving them some good range of vision, but they are still needing reading glasses.
I agree. I think we've done the same thing with micro mono, if you want to call it micro mono, and I think that's provided a bit of additional. So we're still working at it. We had a lot of experience with the Symphony as well. I guess the challenge with Symphony is that we couldn't avoid potential dysphotopsias, and so that made it a bit of a challenge for us. Although one can debate about the contrast difference between a Symphony and a more classical trifocal. So that's where we kind of got stuck with it a little bit. We're excited about Synergy, honestly. I mean, there's some bench data on the Synergy lens, which is the Technis platform with low contrast vision as well. So I think that's potentially an exciting new kid on the block when it comes to multifocal designs. And then the Eyehance, which is, you can consider it in some ways an extended vision lens, although it doesn't meet all the criteria, but does give you some intermediate, but appears to have contrast, which is similar to monofocal, unlike the Vivity. But not as much power as the Vivity. So, we're still working with all of these, but it's nice to have these options and probably customize it. So, it's more there. Let me ask you a question, Ricky. So, I mean, now that we have these EDOF lenses, and again, we don't necessarily know for sure if they have better or worse contrast than trifocals. I don't know if John or Brian or others want to comment on this. I don't know if I can say for certain that Vivity is better. Although I heard Brian, I think Brian said that actually the Vivity had worse contrast than Panoptix. Is that what I heard?
By the measures that were done in the study, yes.
Okay, really? But was it clinically significant?
But not clinically significant under binocular conditions, both mesopic and
compared to Panoptix. So compared to I know compared to monofocal it was, but even to Panoptix.
I don't know if that's actually been head-to-head compared, because they usually just do it against their monofocal.
That's what I thought. Yeah. So I don't know if we have data to compare. I would think with the light splitting, right? Because there's a significant amount of light splitting with all trifocal lenses, as opposed to a Vivity, which are not splitting light. I would think that certainly low contrast vision would be better with Vivity, but I agree we need more data. But let's say we have what we have. I mean, Ricky, let me ask you a question. I mean, since we have a Vivity now, or these EDOF lenses, I mean, why take a chance? And should we just really go automatically to a patient with glaucoma and choose an EDOF lens over a trifocal, considering all this, or is it really the same anyways, and give a patient a chance to have full spectacle freedom? What do you think?
So I agree with Brian, what he was just saying, that the data he showed, it didn't look like Panoptix or Vivity would be clinically significantly different. I think a Vivity in a patient with more advanced glaucoma, I would feel more comfortable going that direction. If you had a patient who had pretty asymmetric glaucoma, maybe something where you do an EDOF in one eye and it may be the Vivity in one eye and a Panoptix in the mild glaucoma eye, I think would be a good option. I know Drew has a lot of experience doing combinations of EDOF in one eye, multifocal in the other, and has had some really good success and happy patients with that approach.
Awesome. Okay. Well, we're going to put up some cases again. Okay. And let's get some answers, and let's kind of force people to give their options. And then we're going to do a poll as well. So we'll let everyone kind of poll what they would do here. As you've heard. And I mean, this group is a pretty progressive group. I will have to call a bias here, because everybody here, except for the Mexican, is completely really progressive and very innovative, right? That's a bias. And to be fair, there are many colleagues in the cataract world and also in the glaucoma world who call this heresy, and they may be right. Maybe this is a very reckless group. So I want to make sure that everybody understands that. At the same time, I really value the experience. I mean, John's had a tremendous amount of experience with these IOLs and glaucoma as we have as well. And so I'm interested to hear what people will do for these cases. Let me put this up here. Pull up these cases for people to discuss. And I'm going to ask each panelist to kind of give their opinion here again. I put this case up before. This is a patient with glaucoma. And again, I want to say ocular surface is great. Keratometry is fine. Excellence is average. Ocular, macula is fine. So there's nothing else that you're going to be thinking about. Personality-wise, they're not, some crazy patient from, well, I'm politically correct here. They're not some crazy wacko patient. They're a good, you get along with them. They seem reasonable expectation-wise. They're not an ophthalmologist. And so, although we have used it in those patients as well, mind you. So let's get that out of the way for a second, okay? And let's assume again that they're maybe on a couple of drops. Whether you combine with MIGS or not, that's fine. You can think about that. But their glaucoma is not uncontrolled, meaning their pressures are not like sky high. Okay.
And one other thing that would be helpful is you want to standardize an age or something on an age, because that's one of the things that I think about.
Good point, John. Absolutely right. I mean, okay, let me ask you. I'll let you give the ages for these cases, okay? So John's going to give us the ages. And maybe we can do two different versions of this. But here's this patient with stable mild glaucoma. Give me an age, John. Let's say this patient's younger. Let's give him a younger age in this one.
Yeah, 62 yeyears old.
62 years old, okay? So let's go around. I'm sorry. Let's go around the room and ask I actually had it there, but let's say the patient is 60 years old. I just lost control here. There we go. Okay, this patient's 60 years old, as John said. Okay, so I'm going to bring in Havo. Havo, what's your call here, buddy?
So, I mean, first of all,
thank you for joining us, by the way. I love you, man.
Yeah, I know you have something against the Mexicans because you're just sad that you'll never have a better Mexican fellow again. So I understand. So first of all, I'd like to ask about the patient's axial length, because this is a very, very mild glaucoma, especially judging by the last visual field. Normal axial length. Yeah. So, I mean, I guess has the IOP been high, or is...
So, good question. I mean, typical glaucoma guy is going to ask me 20 questions before he gives the answer. I get it. Okay. And actually, Gagan asked a good point here, though. How many medications would that change your IOL? It's a good question. Let's say the patient's on a couple of meds, okay? Pressure was T-max was 26, and now they're running at 16. They're at okay? And their CCT, I know you're going to ask this question, is 540, okay?
I learned well.
Half Mexican and half Asian. Anything else? And they're Republican, okay? There you go.
Okay, so I think one of the key points that was made in Brian's talk, and I really liked it, and I actually liked that it was your last point. I thought you weren't going to touch on the dry eye on the ocular surface, but you did, and you kind of like left it until the end.
Quit friggin' hedging here. Give me an answer, dude.
I would not have an issue with either EDOF or a multifocal in this patient, but I would have to talk to the patient a little bit more about certain things, especially their occupation and their workplace, and how whether they work in very dimly lit conditions, because that is something that I ask about a lot lately. You can't just assume that everybody has the same occupation and has the same kind of illumination at home.
But I'm gonna say, like, again, let's say the occupation, they're not a truck driver. They're, I want to get out of the issue is glaucoma here, though. So let's say if they didn't have glaucoma, they'd be a great candidate for you, Hava. They'd be like, yeah, you would do it, but they have glaucoma.
Yeah, for sure.
So multifocal or EDOF?
Well, that depends on what the patient wants.
Okay, all right. Moving on.
Does the patient want to see up close?
Let me, Drew, can you give me you're not a glaucoma guy, so I can count on you to give me a 1 minute answer here. Drew.
Before you get to that, I just want to say, Havo, you would not survive a fellowship with John Berdal. He would not allow a question to be answered with another question.
Drew, throw your thoughts in here, buddy, and don't be intimidated by this glaucoma crowd. I mean, Havo's in Newfoundland. He's on an island, like quarantine. Don't worry.
So this is the 62-year-old, right, with well-controlled glaucoma, minimal changes.
Yeah.
I'd put either one. I would go either one, and I wouldn't really even think twice about it in this point.
Okay.
With the lenses that we're talking about, the modern lenses that have good contrast.
Ricky, let me go to you. I mean, like, Brian gave a very good, compelling talk. And if anybody with glaucoma is going to be a patient for multifocal, this would be the one, right? Stable, mild glaucoma. The visual field is normal, but yet only a third voted multifocal. What are you saying, Ricky?
Yeah, I mean, I think I would consider a Panoptix trifocal in this patient. I would consider the newer EDOF lenses. I don't know that I would put, an old Restore lens or one of the older multifocals in this patient, the Techna series, just because they're a younger glaucoma patient, and we know that glaucoma patients tend to progress.
Yeah, I'm glad you mentioned that point about progression, because that's the part that's always tricky, right? And I think John was getting to that point about age as well. Okay, Brink.
So, I was thinking it's a little pessimistic to say that we're going to fail with this patient, because that's really what you're kind of resigning yourself to when you say that they're not eligible for everything. Like, if we can't keep this glaucoma under control for the rest of their lives, that's pretty sad. I mean, I think we can, in this day and age, to Brian's point about it, with all the stuff we have available. And even more so, in 20 years, can you imagine? I mean, when this patient has a field bad enough to make a clinically significant difference, imagine what we'll be doing then. So, I think you can make the point that it's wide open for this patient. You could do whatever they wanted.
So Brian, I mean, you made a good point. Even if they had significant glaucoma, the contrast loss with a multifocal would not be that significantly different. I mean, what's your vote on this one?
My vote is a multifocal in this patient because the Panoptix is so good. And I am actually very curious, as I'm hearing some of these answers and seeing some of the questions, I'm curious why some people are going to an EDOF lens over a trifocal lens in general. It seems like some people are still favoring EDOF lenses over the trifocal lens. And in our experience, it's just been so nice to have a lens that does all of it for you versus having to think about mini monovision. I'm just curious if you have any thoughts on that.
John, what are your thoughts?
Yeah, my thoughts on that are, interestingly, in that Vivity trial, monocular vision did have a decreased contrast density loss. I think God gave us two eyes for a reason, and they should both work together. And so if you have a trifocal, you get both eyes working together at all distances and are going to have better contrast sensitivity when both eyes are working together. For this patient, I'm doing MIGS, and they can have a trifocal, no problem, or any of the multifocals, or an extended depth, or an LAL. Open range here.
Okay, so I mean, as you see, a lot of points here, and there's certainly good chat on the chat group here. It's always hard as well when you don't have a lot of data, and we have presented cases where we have some progression analysis, but that's always a challenge. So let's move on here, and you saw what the audience voted. Next one here. This patient has a bit more moderate disease, so let me ask the panelists what they would do here. And I will not go to Hava first this time. We're going to go to...
I have a question for you. No,
let's go to Ricky.
All right. So what is the question?
Which lens would you choose here? Same questions before. I'll put the poll up again.
Yeah, I mean, I think this is harder if the patient's starting to have some visual field changes. I think this is where you get into a little more controversy in terms of, a lot of the... I still think the newer lenses, the data that Brian showed, you're not getting a significant reduction in contrast sensitivity. And I think you could potentially consider, how old is this patient, I guess is.
Oh yeah, sorry, John, give us an age for this patient.
This patient's 72 years old.
Okay. I mean, the older this patient gets, I think the less I would have any qualms about putting in, Panoptix trifocal and EDOF lens. I still probably would not want to use one of the older multifocals in a 72-year-old glaucoma patient that's starting to have some visual field changes.
All right, Havo, man, we're going to come back to you, buddy.
Okay, so
what are you choosing here?
I think a key point here is this patient already has established glaucoma. I would like to know, I'm not going to ask a question, but I would always ask my patient, how many drops is this patient on? What's the IOP? And that's key there. So
we're gonna say the IOP is relatively reasonably controlled, and again they're on the same let's say 2 classes.
Yeah, so this is a patient where you're not too worried about having to use, 4 classes and the ocular surface, affecting your result, your refractive result. You can always do a trabecular bypass or excisional MIGS on this patient. So I wouldn't have a problem with a multifocal or an extended depth, as long as the patient understands that they're starting to get into the red flag area where they may either require more drops and have a worse ocular surface, or they may require incisional surgery in the future, and this could affect everything else, right? So this is where you have the conversation. But I think it's still a conversation that I would have with the patient, but I wouldn't push it too hard.
Fair. Drew, what are your thoughts, buddy?
So with a patient like this, you have to think a little bit more about it. And I would look at the total picture of this patient's course. If this is a patient that I know or have been followed regularly for many years, and this was a stable visual field deficit that we had well-controlled IOP, I would consider really any of the options for him. To digress just slightly, when they asked about EDOF versus trifocal, my current favorite combination is actually the EDOF with a high ad a bifocal, like a ZM-BU with a 4-ad, because especially for my short-armed patients and little old ladies, because they can only hold things about 12 inches from their eyes, and so you get a really nice ad. And so that's why I usually consider a combination. Now, in a patient like this, I think he would be a candidate, or she would be a candidate for that combination option, or a bilateral trifocal also does well. So.
Okay, well, looks like again the audience was EDOF again, a little bit more higher on the EDOF, less on the multifocal. Brian, and then John, your comments on that?
My comment is that if this were a patient who presented with high pressures and a field like this, and then got put on glaucoma medications, and they responded beautifully, and they have had a progression analysis like this that were a little bit longer, I would feel comfortable putting any of the lenses in. But it's like we talked about with trajectory. If this is a patient presenting first time, I wouldn't feel so comfortable. And I would probably favor more of a Vivity in that situation for no other reason than it just feels like the right thing to do. And I don't have a good reason why.
And another key thing here, I think, is to look at the other eye, right? Is the other eye worse than this eye, or is the other eye better, right?
So John, yeah, good. That's a good point, John. Let's suppose this is a nice example. We got progression now. This patient comes to you for the first time, John, right? And they have this visual field, let's say, but you don't know whether it's progressing or not. Okay, and this patient maybe is like, let's say, you said 72. Let's say maybe they're 55 years old. Let's say, what would be your selection there?
They're getting a monofocal lens. And I'm actually more conservative than the group was on this. This patient, as presented, gets a monofocal lens with me.
Really? Okay, interesting.
There's 2 things that would prevent me from allow me to do a multifocal or an extended depth of focus lens. If I had a history that showed that they had high eye pressure that got them under control a long time ago, and we've controlled them for a while, and that's what caused the visual field defect, okay, I've got confidence they're not going to progress. Number 2, I'm confident with an IOL exchange. And if we put it in, taking it out and putting in a monofocal is not that big of a deal. And we're giving them a shot at the vision that they'd like to have. But as presented, this one gets a monofocal for me.
Okay. Throw a curveball, man. Good to reorient us a bit.
Yeah, you all thought that John Berdahl was really progressive, but he's really not.
John, you're getting old, man. You're getting old, buddy. Brian's overshadowing you already.
Right. That's because
I would actually be reluctant. I don't disagree with you at all. I mean, I'm a bit conservative on these because you just don't know what's going to happen with the progression when you don't have that information. And I think that taking the chance, I mean, even in the best of cases, sometimes we have patients who are not thrilled with their vision sometimes. So it's a bit of an issue. I wanted to ask the group because Barbara makes a good question here. Barbara Tabul saying, I've always thought better quality contrast with Symphony due to less chromatic aberrations, so often choose it, even though there's less of a near vision. So what do you feel about that in terms of that aspect of a Symphony, for example? Is that statement true? And if so, does that kind of incorporate in your decision-making? Certainly the audience seems to be looking toward EDOFs a lot.
If you look at a lot of the studies looking at the Symphony lens in particular, the Symphony lens has reigned supreme on photic phenomena. There is one unique photic phenomena to the Symphony lens, and that's starbursts. But aside from that, there's a lot fewer issues because of chromatic aberration, the transfer modulation function. In other words, the amount of light that makes its way through that lens is really excellent. And you do have higher rates of glare and halos with the Panoptix lens. Over 60% of patients with a Panoptix lens will say they have glare and halos, but 98% of them will say they would get the lens again because they're not bothered by it. So it's a real factor in those lenses, but it's also something that patients say like, oh yeah, I do notice that, but they're not that bothered.
Fair. Okay. Let's just put this one out here.
Monofocal.
Anybody do anything other than a monofocal here? Let me take a poll here. Anybody here? Ricky? Havo?
I'd want to go with a monofocal on this one. And I did see a really great comment in the chat, someone asking about the last case. Would we consider a MIGS procedure in combination with cataract surgery on that patient?
Yeah.
What are your thoughts on that, John?
Yeah.
I think you're commenting on that as well.
Yeah. Yeah, and probably kind of what I would say MIGS plus. Maybe we're not just doing a trabecular bypass approach or a goniotomy. I'm maybe adding ECP or something like it. And if it's, you know, a subconjunctival glaucoma surgery that they're getting, they are not getting a multifocal or an EDOF lens. No way.
Yeah, I think you're right. Part of the problem is just hitting the refractive target, right? And the variable surgical induced astigmatism, even with a less invasive option. So I think that's a valid point. And the same reason with like a nanophthalmic angle closure eye, for example, where the refractive, accuracy may be a challenge in a glaucoma patient. You may not want to go through laser vision correction depending on the patient. So that would be maybe a factor. And the pseudoexfoliation is always one that kind of challenges me as well. I think, Brian, you alluded to that.
Yeah, can we talk about that for a moment? What are your thoughts on somebody who comes in, they've got a ton of pseudoexfoliation material all over their crystalline lens, but pressure's 9, they have no visual field changes, they've got a cup to disc of 0.3, but they've just got pseudoexfoliation material all over the place. What do you think about with putting in an advanced optic lens in them?
So I have my own thought, but maybe I'll put it quickly to Havo and then to John, give their thoughts. And Havo,
so,
I got to finish it up soon, so I'm going to give you 30 seconds.
All right, so the main concern here would be dislocation. And of course, the secondary concern would be glaucoma. But if the patient doesn't have glaucoma, then again, it comes down to a conversation on what could happen. If the fields are completely clear and the OCT is nice and healthy and thick, I think it's a conversation. But I would be more worried about dislocation here than anything.
John?
If there's no phacodenesis, they can get a multifocal IOL for me. But I also tell them it's a game time decision if we see phacodenesis at the time of surgery. So no phacodenesis.
That's good.
Okay.
That's a good point. Yeah, and I agree. I mean, studies have shown that the amount of pseudoexfoliating material in the eye doesn't seem to correlate to the incidence of glaucoma nor zonulopathy. It may surprise other people on that point. Other factors do, yes, like AC depth, like pigmentation, like IOP elevation, things like that, or density of lens, but not the amount of pseudoexfoliating material. If this was maybe a younger patient, I would be worried because in the long run, they may have an issue. But if this patient was a classical 70, 75-year-old, as John alluded to, and they have no glaucoma, I would be okay as a game time decision. Maybe I put a CTR in just in case they have something subtle. I could address it. And if this post-operatively was a problem, I'll hate to admit it, but I have sutured in a number of cases. I think Matthew knows a case recently of a multifocal lens that was on the retina. We brought up and sutured it right in the retropupillary space, and the patient was doing pretty well. I think, Matt, aren't they doing pretty well? They're pretty happy. So,
hey, can we go back to that mild glaucoma patient? Yeah. I'd like to know. It's one thing to talk theoretically about what we would do if our patients wanted it. But I'd just love to go down the panel real quick and say, which lens would you have if it was your eye?
I knew you were going to ask that question.
Not necessarily the brand, but type.
All right, well, let's do that. Drew, what do you think, buddy? This is
I would put in a EDOF into the dominant eye, and then I'd use a high-ad multifocal in the non-dominant eye to give a maximum range of vision.
Okay, Ricky.
That's your eye. That's what you're doing in your eye.
My eye, you bet.
Yep, got it.
Yep.
Yeah, I'm pretty sure I'd want a light adjustable lens with monovision.
Okay. Havo?
I'd probably go for a Panoptix there, or a trifocal.
And Havo's had RK and CK.
That's right. And I have a focal macular laser too.
Hey, Drew, you're getting some good feedback. Like, Drew's the man. The best answer so far. There you go. Okay. Brink?
You know, it depends who's doing my surgery, JK, but
you can pick anyone you want.
I think, you know, I'd get you to put a monofocal in if it was today. Like, I don't feel like I have enough, you know, of a track record yet with the multifocals to be that confident. So if I had to make a decision today, it'd be a monofocal.
So we'll go to Brian.
Bilateral Panoptix all day.
John, you want me to answer before you? Let me answer before you. I don't know if I do well with a multifocal. I'll be honest with you, just because I know my nature, and not so much because of contrast, but just potential risk of dysphotopia. Again, my own personality and what I'm like. I don't know what my fellows think. I don't know what you think, Havo and Matt. If that's true. I would be open to an EDOF lens. I would be honest. I wouldn't mind a different material, as someone alluded to. I wouldn't mind a different material. So that'd be one thought. So for me, it's basically thinking of an EDOF or some mini mono with a monofocal lens. That would be my choice.
Cool.
What are you doing, John?
I'm going with a bilateral trifocal, but I want to make sure my surgeon is comfortable with an IOL exchange.
That's a really good point. And I want to make sure my ocular surface is amazing. Otherwise, monofocal.
Those are great points.
Look at the diversity though there, Ike. Isn't that fascinating?
Yeah.
That we had, I don't know, 7 different panelists and 5 different answers.
Yeah, it is quite fascinating. So Evelyn wants me to poll the audience on this case. So I'm happy to do that. So the question again is this patient here? Let me quickly share my screen again. So I love that, John. Great move to get the group to think here what they would do. So this is your eye here. We're going to poll the audience here what you would do in this case here. Quickly, this is your eye now, as John said. This is your case, and what would you do in this example here? And
Can you add LAL, Ike, or is it too late?
I didn't. I could add LAL. I could add LAL. I mean, I already lost the poll though.
I'd just be interested.
If you're doing an LAL, right in the chat box if you're going to do an LAL, and then we'll count it in there. So where's the polling gone? So you're seeing basically, yeah, you got monofocal now. So interestingly, the group, remember, was more EDOF, and it looks like the EDOF group moved over to the monofocal, while the multifocal group was kind of the same, about a third. So we had some people moving a bit over to the monofocal side there. So yeah, it's interesting enough. And again, it just goes to show that, I mean, it wasn't wrong to choose a different lens for a patient, but we know our personalities, right? And we probably are a little bit of a biased group in terms of our obsessive and what we know, I guess, in that sense, right? So that's a valid point. There's been a lot of questions here. And so, and I think as people have mentioned here, there's still a lot more we need to know. I think that, looking at a contrast sensitivity curve, I hope we all will look at it maybe a little bit with a bit more insight, as Brian very nicely alluded to. I haven't seen a better presentation to a more layperson audience like myself on what this means. Matt, I'm looking through any of these questions here to quickly answer the group. If these were chronic angle closure rather than POAG, would it change anything in general? Does it change anything on that question? Anybody want to take that one? Or is it basically the answer is going to be the same, whether it's chronic angle closure or
to the
POAG?
fact that it might make things better. Whatever lens they put in will make their situation better, getting a bulky lens out of that space. So maybe that opens up the options. I don't know if that's what they were getting at. Saying that it's going to cease to progress once we address the problem of the angle closure by taking out the crystalline lens.
The only thing I'd add is that if unless it's a weird funky eye with a relative anterior micro-ophthalmic eye or like a non-ophthalmic eye, where sometimes those IOL calculations are challenging. Although we could do an exchange or laser vision correction, it's just a bit more challenging in those cases. That would be a little bit of a strike against it. Not completely. That's the only thing I would add to that. Been a few questions about normal pressure glaucoma. I think, John, you did answer that. Any thoughts? I mean, does the fact the patient has NPG versus high pressure glaucoma that's been treated, does that make a difference in your choices? You kind of mentioned it a bit here on the chat group.
It does for me. I don't have a lot of confidence that I'm going to be able to stop NTG without maybe needing some sort of subconjunctival surgery down the road or some new technology. So yeah, it seems like a good answer, right?
Well, I got to put a plug in for the work you're doing and with NASA and with glaucoma patients with the Equinox, right? Because we need a way to get IOPs down in MPG and using a multi-pressure dial. I mean, if you haven't seen it, guys, look it up. It's very exciting. It's completely novel. And John and his group is doing some great studies on that, which I'm excited about. I think you're right, though, John. There's some unpredictability in what MPG is going to go. And
also some unpredictability in where the visual field is going to be, as well. The visual field defect is going to be, right? They can be more central as well.
Does hysteresis make a difference as far as decision-making, measuring corneal hysteresis?
It does for me, especially if I don't have a history of visual fields. So if they come in and I've got one new visual field, or maybe one that was done on the outside and they've got a low corneal hysteresis, I'm more aggressive with that patient. And Felipe Medeiros has showed some really nice work showing that the risk of progression is a lot higher if you have a low corneal hysteresis. So it does for me.
Good. I think Gagan asked some good questions. Your refraction, right? How does it make a difference? I mean, if it's a patient's highly myopic, does that make a difference? We have some of these highly myopic patients who got, mild to moderate disease, but they're quite myopic. What do you feel about these lenses of myopic or highly myopic patients?
Yeah, I'll take this one, Ike. So I think that what it really comes down to is the same thing as the normal tension one. It's this right here. What is their trajectory going to be? And I think that in those highly myopic people, sometimes it can be more unpredictable, particularly because they have funky optic nerves that you just don't even know how to follow as well. And the refractions may be stable in them. You're going to be able to get an IOL that's okay, but it's just that uncertainty of how that patient's going to do.
Thank you, Brian. That's insightful. Anybody want to add any more comments on that part? I mean, I think, there's issues with regards to their myopic impact on their vision, which we know can be reduced, and also, again, their IOL predictability. I think those are both factors in there. And I have to say, for a high myop, I generally avoid multifocals in general for the reasons you mentioned. Yeah. I'm still thinking about what about EDOFs. I mean, but I would probably be more toward, and again, the powers aren't even available sometime, right? For these patients, so it may not even be an issue there.
Yeah, I try to stay away from EDOFs and multifocals and anyone with high myopia, whether they have glaucoma or not. There's also retinal complications, And
the VR surgeon, Vincent Fan says the VR surgeon would thank you. James Murphy and Barbara's having a conversation about SSNGs, and that's basically a subtype of glistenings, which is more of a whitening of the subsurface of the lens, different than the classical, stromal glistenings and vacuoles. These are more significant in their issues around glare, which has been shown in some lenses, particularly some of the older Acrosoft preps with the newer changes and water content. We seem to see perhaps less on this one, but that's a whole other issue, of course, as well. Okay, great. And some great questions on there about keeping the foveal testing, threshold testing, and 10-2s. Great comments. I hope everyone reads that. Last question here that came up in the chat, in the Q&A. So when you have a new lens, maybe I'll throw this to Drew and then John. You have a new lens, okay? The marketing people are saying it's the best lens ever out there. How do you assess the performance in your hands, in your patients, in your clinic? So how do you do that, Drew?
So the first thing I ask them as soon as they bring up a new lens is to send me every relevant document that's ever been published about it from everywhere around the world. And they're usually pretty good at getting me quite a bit of it. And I'll read through those and kind of see, okay, make my own independent decision. It is what they're telling me about this lens playing out in the actual studies that they sent me. And then I'll go do my own research and dig into it a little bit further and see, okay, what's been written on it. And, here in the US, we have the advantage and the disadvantage. The advantage that we get to see a lot of the studies before we use it. The disadvantage that we don't get to use it while you all get to have a lot of fun up there and elsewhere. But But that's for my first thing is to do the due diligence on the background of it. And then if I'm going to bring it into my clinic, if I believe that it's better in some way or multiple ways than what I've been using, I'll go ahead and talk to patients about the different options, and I'll tell them these are the advantages, and oftentimes I'll let them choose it. And if it really is what it says it is, it typically goes pretty well. And again, that is the advantage of being in the U.S. We get to see what you guys have already figured out, sometimes the hard way, most of the time not, but sometimes we get to see that advantage ahead of time. So we can be a little more confident, I guess, in that regard of knowing that you all have posted all these wonderful videos and you've done these wonderful talks and done all this wonderful research for us. And so, by the way, thank you for that, and everybody that's doing those early studies, because that's so helpful to us. But yeah, that's where I'd start, and then I would put it into a few patients to see how they go. Do a small study of my own, essentially, and if it plays out in my patients, what's shown in the research, what's shown in the research they sent me, what's shown in what they said to me, then I will believe it. But I really don't believe it until that's happened. Or also I'll look up a lot of different talks on it and hear what your guys' opinions are, what you've thought about it. So again, what you guys do is extremely valuable to us, because that all those things come together. And if you verified independently, the other experts agree, you see it in your patients, then you can kind of believe it. So that's sort of my pathway to getting to do something new.
That's a great algorithm. I love it. I got to get maybe the newer whatever Z generation this is going to be with Devin here, who's just made his first appearance. One of his first appearances probably on a Zoom webinar, who's looking mighty alert and awake and waving at us. So nice to see your little guy there, Brian. Congratulations.
Thanks. He's 3 months. He's great.
He's an awesome little guy, and he actually had his bris over Zoom. That I had never done a Zoom bris before, so that was pretty exciting. But the question about adopting new technology is an important one, okay? And I think that we want to ask ourselves the question, are we going to do things on our patients that we wouldn't consider doing on ourselves? In our practice, we have a little bit of an unfair advantage because we're in a lot of the IOL trials, so we get some highly controlled early experience with it. Again, I'll reiterate, being comfortable with an IOL exchange is really important. But you kind of have to do it. I do think trusted colleagues are a very good source of information, but experienced trusted colleagues, not a colleague that you like that's never done it, that has a strong opinion about it. And then the final thing that I'd say is, once something gets FDA approved, I think that it goes into a realm where we as the doctors start to investigate it outside of how it was studied. And so things like IITs, investigator-initiated trials, where we go and say, we've got a question. Sometimes the company will support them. Sometimes a company won't support it. But we go and say, hey, I wonder what these lenses, how they do in glaucoma. Let's formally study this, because there's 20% of the patients out there that have cataract surgery or so that have glaucoma. And we don't have good science to guide us in that patient population. So we're trying to extrapolate the good work that Brian's doing here and try to apply that to a glaucoma patient when we haven't studied it there. So a lot of those of you listening, that's a great way to contribute to the science, even if you're not in an academic institution.
Well said. Well said. I think, I think picking good patients, right? Someone who's got a good temperament, good personality, that if there was a challenge that they would understand it, and being open and transparent, I think is key. And in this day and age, we're lucky to have good data to support it. And I love the idea of, I think we all, I hope, are comfortable doing IOL exchanges. They're not always benign, but doing it in the first few months, I believe, is quite manageable and within the realm of an IOL surgeon, which can be done, I think, quite safely. So very well said. Well, I want to thank everybody. I want to give everyone a last word, as we often do, as we go around. So maybe I'll start with you, Havo. Thank you for joining us. I mean, I know you weren't planning to, but I always love to get your thoughts and
always a pleasure.
Wisdom. So thank you. And anything you can for this last, you can say anything you want. It could be about ophthalmology, cataract, IOL, life, surfing, politics, COVID, whatever you want.
I'll skip the politics, and I'm tired of COVID. So I just want to expand a little bit more on what John just discussed. And I think it's important to do your own case reviews and chart reviews and the own analysis of your results, and try to be as objective as possible, because you either tend to focus on the cases that went well and convince yourself that everybody's happy, or you can tend to focus on the cases that didn't go well and end up leaving a technology that was actually working well for you. So especially when adopting new technologies, I think you need to do really good follow-up, really good charting, make sure that all of your data is there, and then go back and actually look at it and analyze it using the adequate statistical tools to get an idea of what your own results are. And I like to do that personally.
Great points. Okay, Ricky and Matt, you two are you know, just starting here. Give some. And I never say you're never too early in your career to give good advice on or inspiration to others. I love hearing from those that haven't yet traveled the path I haven't, gotten so jaded yet, or have, you know, a more open mind or a more malleative way to think about things. So Ricky, give the group here. You got some international group here. Even got Hanel from Mexico joining us, by the way. So Ricky, give us some words of inspiration.
Yeah, so I actually just wanted to mention something I saw come up in the chat. James Murphy had some comments about astigmatism correction. And I don't know that we touched on that too much, but I think astigmatism correction is really important in our glaucoma patients. You know, if we can, you know, put in a toric, these patients with higher degrees of astigmatism, you know, the better, the more crystal clear we can get their vision. I think you mentioned earlier, kind of alluded to lens materials. Silicone materials have a really good optical quality. And, you know, if this were me looking at a surgery, I think that I would want the most crystal clear vision I could possibly have if I'm a glaucoma patient coming into having surgery. So I think I would give consideration to lens materials. I would give consideration to correcting astigmatism, as well as addressing their desire to be glasses independent and talking about presbyopia correction and whether or not that's the appropriate choice for a particular patient. Thank you.
Matt, by the way, we have some suggestions for some topics on the chat group, so maybe take a note of that as well.
I feel like we need a part 2 of this.
Well, yeah, it's a lot to talk about. Matt, any couple last points for people?
Yeah, I'll use my minute or two to say thanks, guys, for letting us participate on this and sharing your insights. It's awesome to be a part of this. So also, you know, a question being sort of on my mind is, you know, what was their intention with the development of this Vivity lens? Were they sort of secretly trying to target or present it in a way that would be more sort of palatable to people like us, putting them in patients with mild field loss, et cetera? Or is that too risky for the company to do that, like outright? And I don't know, it's kind of an interesting thought. Like, what was their intention? Are they trying to get us to do just this? Say, hey, look, we can put these in people with field loss and et cetera, without really saying it? Or are they outright just, you know, I don't know if you guys want to answer that, or if it's something just to chew on.
I think the biggest thing was the need to have something that extended vision without the risk of dysphotopsia, right? Yep. Which is a big reason why people don't use lenses and why patients often decline, right? So if we had a lens that can give you, you know, 20/25, 20/20 intermediate, and, you know, 20/40, 20/50 for reading, you know, that's without having dysphotopsias, or like monofocal like dysphotopsia. If it's true, we'll see. I think it is. That's a pretty big need right there. You know, pretty big need.
I think Ike's exactly right. And keep in mind that when these lenses are developed is 10 years ago, or when they're starting to get, you know, developed. Yes. So you don't know where the puck's going to be 10 years from now. And so you're trying to get more shots on goal.
True. Hey, John, whenever I see you on Zoom, you always have your passport on your desk. Are you like going somewhere all the time or something?
I'm going to El Salvador tomorrow.
Are you really?
Yeah.
Nice, man. Be well. Be safe, brother.
Thanks.
Okay. Drew, any words of inspiration? Could be anything. Doesn't have to be ophthalmology. Like I said, we're gonna go to you, then Brian, then John. You're gonna have the last word, man. Just to give the audience, give something really inspirational here. Sorry, man. Put you on the spot here, Drew. My bad.
Well, I don't know if I have anything inspirational. I'm still pretty on the ophthalmology side, but I'll just say to the young surgeons out there, just coming out of sort of that first 5 or 6 years, the number one thing you can do to be a great refractive cataract surgeon is to be a safe surgeon. You can't put a multifocal lens in a bag that you just blew out. Well, maybe if you're in Canada and you have some of the multifocals that are 3-piece, you can. But you have to be safe first. So find all the mentors you can. The best decision I ever made coming out was to quote unquote negotiate for a mentor for my first 3 months to be there for every case. And I took a different route than a lot of you guys. I didn't go the fellowship route. I just went straight into high volume surgery, and I averaged like 3,000 procedures my first 5 years. And without that 3 months of mentorship, no, it would have been really hard. So you guys are all probably smarter than me because you all found really great mentors, and with Ike and all those guys. But if you do find yourself in a situation making the next step, take it slow, be safe, and make sure you get good mentors to learn from. So you guys are already ahead of the pack on that. But anybody else out there that's doing it maybe a little bit more on their own. So for sure.
Well, thanks, Drew. I can tell you that, and you heard it on the chat group, when you're the kind of person, when you speak, I mean, you may say it in less words, but they're powerful, man. You say it with great emphasis and with thought. So I'm looking forward to more of your advice over the years. Thank you for joining us.
Thanks,
Brian. You were awesome, buddy. You were the star presenting here, and you're so early in your career as well. I love to see that, and you're gonna do great stuff. Any words of inspiration for everybody here?
Yeah, first I just want to say hi, Mom and Dad, who are on the call right now. Love you guys.
They should be proud of you, buddy.
The most important thing that I have learned since being a learner has been how to listen to a mentor and really take their advice. And this piggybacks off of what Drew was just saying, but finding John Berdahl and fortunately matching with John Berdahl has been the best thing for my career and me as a person, to not just focus on my career, but to focus on me as a person. And I think that's the key. We're all living in such an odd time, and it's easy for us to jump on Zoom and see each other, but it's hard to just sit on the couch and look at your spouse and just feel comfortable right now. And what John Berdahl has taught me is that family's first and then beloved profession comes afterwards. And we're just so lucky to be part of this beloved profession. And I'm just so honored that, Matt, you've invited me to join in with Ike's rounds. And John, thanks for joining me as well and being such an incredible mentor to me.
Well, John, that's a great tribute to you, my friend. I'd like you to give you the last word here to give the group a great inspiration as we go through this time, and we're all, of course, waiting for us to see each other.
Yeah, no, thanks, Ike, and thanks, Brian, and really great job, everybody. I would say that we're all in this together, and I think that we are in the best profession in the world in ophthalmology within the subcategory of medicine, and it's probably hard. It's hard for us to give back more than we take out of this world, because this world gives all of us a lot as ophthalmologists. And so find a way, be purposeful and find a way to give back. Somebody like Ike gives back a million different ways in doing stuff like this, but whatever that is, whether it's being a mentor or contributing to the literature or teaching or community service or international outreach or whatever it is, find a way to try and be a person that gives back a little bit more than you take out.
Well, thank you, John. You do definitely live that, and I think it's so true. I think we often gain more when we give something and get something more out of it ourselves. So it's great. On that note, it's been an amazing hour and a half. I mean, it's gone by so fast. Really great interaction. I think the group really enjoyed it. So thank you for donating an hour and a half of time for this. This will be on our YouTube, so they'll be seen by many more people as well. It was a great topic, and I wish you well. John, safe travels, buddy. Be safe, be well. And we will see each other soon. It's going to be amazing when we see each other in person, man. So
can't wait.
Everybody, keep well, be safe.
Screenshot. Don't go.
Thank you guys so much.
Oh, take a screenshot. Sure, screenshot. Who's going to screenshot?
I'll do it. All right, smile.
Got one too. Okay, guys, and happy Thanksgiving, yes, to my American friends.
You too. Thanks, Ike. Thanks for doing all this extra work.
Thanksgiving. Great talk, Brian.
Great talk, Brian. Thanks for having
the guest appearance, guys.